This is Dr. Kathryn Dao reporting for Room Now. I'm at ACR 2021 Convergence, and I have a delightful guest, Dr. Seoyoung Kim, and she's the recipient of the Henry Kunkel Early Career Investigator Award. Welcome, Dr. Kim. I really appreciate you taking the time to be with me today.
Thank you for having me. It's a pleasure.
So you're one of our rising stars. How did you get involved in rheumatology and rheumatology research?
I think I always liked rheumatology as a medical student. I grew up in Korea and I went to medical school in Korea, and my medical school had actually a large rheumatology program. So naturally, I was exposed to many serious and severe cases of rheumatic conditions. And then after I moved to the US, the first research opportunity I got was actually at the University of Pennsylvania under the mentorship of Dan Arbert, who is now at Dartmouth. So, since he's a rheumatologist, I had the pleasure of shadowing him in the rheumatology clinic, and I just fell in love with clinical research and as well as rheumatology as a clinical medicine. So that's how I started out, and it's been I don't know, depending on how you look at it, short or long journey, but yeah, it's been fun.
Well, to me, I think it's a beginning journey for you because there's so many exciting things that you are doing. And I've noticed quite a lot of posters with your name on it. And especially, cardiovascular risk. It is such a big thing that we are looking at right now and a big topic at ACR. So you have had like a few abstracts. One is looking at hydroxychloroquine and cardiovascular risk in rheumatoid arthritis. The other one is tofacitinib and the cardiovascular risk in the real world. And then also gout, like treating to target, whether or not that has any impact on a major adverse cardiovascular event. So I'm just going to take each one, and I want to talk to you about it because, there are certain things that you can only fit so much into the abstract. And I'm sure there's a lot more behind the scenes. And I want our viewers to get a chance to know what that is. So let's start with abstract. It's a late breaking abstract, number 11 with hydroxychloroquine. Could you give us a really quick overview about what you studied and what you found?
Yeah, so actually this study started before the beginning of pandemic. So initial intention was actually looking at the cardiovascular safety of methotrexate in rheumatoid arthritis, triggered by the disappointing result of SURTRIAR a couple of years ago. And then in order to study methotrexate, I had to kind of determine what would be the best competitor. Because when you're doing an observation study using real world data, it's very important to know which drug is going to be used as a reference, because unlike trial, we don't have a placebo in real world, and if you use actually non-user as your reference, just like placebo in trial, you will really trigger a lot of bias and confounding. So that's how initially got started, and then pandemic unfortunately hit us and affected us, and it's still been really bad. During, as we all know, the hydroxychloroquine saga was in the media all the time, and I think that's probably when we all kind of got an email and then a lot of questions from patients and the public about arrhythmia and other cardiovascular safety of hydroxychloroquine. So we basically added a couple more outcomes to our original protocol, which didn't really include arrhythmia and other things, because it was actually just for methotrexate, like I said. And then once we started dive into more for the cardiovascular safety of hydroxychloroquine compared to methotrexate, we actually found reassuring data with regard to the arrhythmic potential of hydroxychloroquine compared to methotrexate. So that's, I don't think, is anything that we should worry about in terms of the dose that we use for hydroxychloroquine in rheumatology, which is different, much less, and much given more, more prolonged pattern rather than like a couple of days intensive for COVID initially last year. But then at the same time, what we also found is, we use Medicare claims data, and then part of Medicare claims data, the strength of this data source particular is, that we have a linkage to National Death Index, so we can also determine cause of death. Usually, if you just have Medicare or other claims data, all you get is like all-cause death. But here we have a cause of death. So we wanted to look at, all-cause mortality risk, cardiovascular mortality risk, and heart failure was one of it because we thought it would be interesting endpoint as heart failure or cardiomyopathy is, somewhat concerning outcome related to hydroxychloroquine, and we kind of all knew about it to some degree. To our surprise, actually, the hydroxychloroquine is associated with an increased risk of heart failure compared to methotrexate. And I think it's kind of across whether they had history of heart failure at the beginning or at baseline or before the initiation of either treatment or not. So, it is possible, or maybe it actually is maybe more pronounced, the effect of hydroxychloroquine on heart failure or the cardiac function. Maybe it's more pronounced than we as a rheumatologist think, because I think sometimes, and this personally, me, unless patient has very, very bad heart failure, I don't particularly feel very strongly about not using hydroxychloroquine. If they are on just small dose of Lasix, I don't know, I'll be like, oh, you cannot use hydroxychloroquine. I don't think I'll be like that. And, it's also shown in the data because in Medicare, older patients, a lot of patients with history of heart failure with the use of diuretics at baseline are getting hydroxychloroquine. So there are many rheumatologists and many other physicians who prescribe hydroxychloroquine somehow felt comfortable prescribing hydroxychloroquine with a patient, in patient with a heart failure history. So that's something that I think that we need a little more education and a little more caution in our practice. And then I think because our study includes very old patients, the mean age is early 70s. So it is possible that this is only true in Medicare, age population. Maybe it's not so bad if we study younger patients. So something on those lines need to be further studied.
Yeah, the results surprised me. I was a little bit shocked because, I've been asking a question, well, could it be that these doctors prescribe hydroxychloroquine to patients who have so many comorbidities or multi-complex morbidities that, that's the reason why that drug was chosen? And then is this going to impact our practice? Should we be thinking about, getting an echo a few years or a decade of patients being on it? Or, are you going to avoid hydroxychloroquine in heart failure? So that actually opens up, a big can of worms, in my opinion, that really needs to have a lot more data and to study. But kudos to you, because that was a lot of work to try to put together that data. I really appreciate you highlighting that. But, we'll continue to see, and follow your work and how this turns out. Now, the next study that you did was the late breaking abstract number L06, and it's about gout and treat to target with MACE outcomes. Could you tell me about that and your thoughts?
Yeah, so my colleague Kazuki Yoshida presented earlier this morning as a late-breaking abstract. The detail or the hazard ratio, I don't remember off the top of my head. We can probably refer to the poster. But the rationale that we did this study actually was to look at the risk of cardiovascular events in relation to the type of treatment strategy they get for gout. So it is funded by NIH and IM's R01, and it has a two-part. The first part is actually looking at the different treatment, gout treatment strategy on the risk of gout flare, which we are still working on. A part of it was presented at the ACR, but we don't have a full outcome. The second aim was actually on the risk of cardiovascular. So what we thought was, some of you probably are familiar, the uric acid is, risk factor. Hyperuricemia is a risk factor for increased cardiovascular comorbidity and mortality. And many people believe that treating high uric acid level with a urate lowering drug may reverse the risk or may reduce the risk. So the thought behind our particular this study was, if we do more treat to target strategy rather than just initiate allopurinol or febuxostat and then see what happens. If we do more tight control and more routine, regular monitoring, not only their gout improve, but maybe their other comorbidities such as cardiovascular risk may improve. Or the other possibility is if we look at the febuxostat safety study, the CARE trial, maybe not through the urate lowering mechanism, maybe something else, due to some other issue with the febuxostat, maybe tight control of urate with either allopurinol or febuxostat could potentially worsen their risk of cardiovascular. We don't know, right? Because none of these is really studied in the past. So ideally, obviously, this should be tested in a trial setting, but it's, expensive, takes time, or the stuff. So we decide to use the linked data set between Medicare and our institution's electronic medical records. So we looked at a patient with a gout who started either allopurinol or febuxostat, and then kind of saw them through their treatment course and see how the tight control versus just starting urate lowering therapy. And then we have several other different treatment strategies that we're looking at, and then see the impact. I think one thing we can say for sure is it doesn't look like the tight control or treat to target strategy is worsening the risk of cardiovascular disease. We had Moody's point estimate that kind of suggests potential benefit, but we don't also want to overinterpret our data. We are very careful, try to be careful, because maybe there is some confounding. Again, this is a observation study, so it's prone to having all this bias. So if some patients who are very good at following up, getting blood tests, seeing their rheumatologist or PCP, and taking medication as prescribed, or those are like good behavior, right? Good behavior patterns, and maybe that kind of not just a treatment strategy, but patient being very good at maintaining their health and keeping their appointment, or that characteristic are contributing to a better risk of cardiovascular. So we are not trying to really say that treat to target is decreasing the risk of cardiovascular, although the point estimate is a little bit, showing it that way. But, I think we need a confirmation by, with probably a pragmatic trial or large clinical trial that's free of confounding. But as far as we can tell from our data, the tight control treat to target treatment strategy seems to be fine with regard to the risk of cardiovascular.
Yeah, and who knows what would happen, if the trial had a much longer follow-up too. So
right.
It'll be interesting. And then the last abstract that I'm going to pick your brain on is abstract number 1939, which is the real-world data of tofacitinib and cardiovascular risk. I mean, FDA warnings, and this year has been very interesting regarding TOFA. So go over that study with the real-world data. I mean, if you'll summarize that.
Yeah, so this has been fun, time for a person like me who does drug safety research. This particular abstract and study is designed and conducted in our effort to, test and duplicate what the oral surveillance TOFA clinical trial has shown. Unfortunately, we don't have all the full, details of a trial because the paper is not out yet. But what we had was, the full clinical trial protocol is available at clinicaltrial.gov, just like any other clinical trial that are being conducted. So after we heard about some FDA initial communication and media report on concerns related to increased risk of MACE outcome in this TOFA trial, we thought that, okay, this is a trial, and trial was only done in patients with a high risk, high cardiovascular risk. And obviously they have to have a rheumatoid arthritis, and they have a very strict inclusion criteria to enter or be eligible for their trial, just as usual for any trial. But this was cardiovascular outcome trial, so they had a little more, inclusion and exclusion criteria for that. So what we did was using 3 different real-world insurance claims databases in the US. We tried to, have a more generalizable RA cohort to study the cardiovascular risk of tofacitinib compared to all 5 TNF as a class among patients with rheumatoid arthritis. And as a subgroup within that large RA cohort, we mimicked the trials inclusion and exclusion criteria as much as we could. We don't have exact same criteria. We cannot use exact same criteria because, we don't have some of the clinical component in claims data, but we had like same age restriction, same restriction related to their underlying cardiovascular history and things like that. So we had the real-world evidence cohort we call, and then the RCT duplicate cohort, which we tried to mimic the oral surveillance inclusion exclusion criteria as much. What we found was, interestingly, that in the real-world evidence cohort, there seems to be, not so much different in terms of cardiovascular risk between TOFA and the TNF as a class. But in the RCT duplicate cohort, the point estimate suggests an increased risk of cardiovascular events for tofacitinib compared to TNF. So I think it is still challenging why this is the case, right? Like, maybe there's some kind of treatment heterogeneity that we cannot fully explore given, the relatively small sample size and, relatively short treatment time. But I think that's potential explanation. And I think our study, in my mind, is very important and practical because these are like totally representative of the patient that we see in the clinic, right? Like the trial populations, some of them probably are in our clinic, but most of the time, we don't have always like older patient with a high cardiovascular, risk. So I think, just strengths of using real world data for drug safety research, as long as you have good method and good study design, you're careful about how to analyze data, I think we can really provide more practical and generalizable data. And then definitely, we hope to, fill some of the gaps that we have in the literature, and hopefully can be used in clinical care.
No, absolutely. And it is very important because it compared to trial data. And I think that, it cautions us that there are certain people who might actually have a little bit higher risk. And as long as you counsel your patients and, kind of judge the risk benefit profile, then I think that TOFA could be safe. And so I know, thank you so much for your time. That was like incredible in terms of all the research that you've done and all that you've contributed to the world of rheumatology. So I just want to tell our viewers, continue to watch us on Room Now. This is Dr. Kathryn Dao reporting. Follow me on Twitter at KDao2011, also known as the Dow Index.